Multi-drug resistant TB has been around for quite a long time, but how did it originate?
So initially the problem was that patients weren't being treated appropriately for sensitive forms of TB. They either weren't prescribed the right medications or they weren't given them in the right combination, and some of them had other very pressing health and socioeconomic needs, so they weren't able to take the full 6 months of therapy. When you don't complete the full 6-month course, you don't have a chance of being cured, and you have the chance of having resistance development. That was 20 years ago. The situation we're in now is MDR-TB is primarily being transmitted in the community. So patients who've never had TB or ever taken treatment before are becoming sick with strains. So it's now one of the main circulating strains in the community.
So what's the proportion of drug-resistant TB that's around right now?
So it depends on the country that you look at. In places like Kazakhstan and other settings in the former Soviet Union, upwards of 30% of their patients have drug-resistant TB. In some of the lower burden countries where it's not so much a problem, it may be less than 5% of their patients. But the numbers keep increasing.
Your particular interest, though, has been children recently in the Sentinel project. Can you tell me about that?
So the Sentinel Project on drug-resistant tuberculosis is actually a virtual network of providers who care about children who are both infected with, affected by, and sick with drug-resistant TB. One of the most startling numbers to come out of this conference was the growing gap between being diagnosed with MDR-TB and actually being started on treatment. That gap is increasing every year, and children are always left behind. So we estimate in our project that there are about 35,000 children with MDR-TB every single year, and fewer than 1% of them are ever diagnosed or started on treatment for their disease.
Why is this particularly an issue with kids, though? What's the difference between looking at kids as compared with adults?
Yeah, so children actually are a great reflection of ongoing transmission in the community. So seeing these problems in children tells us there's a larger problem with transmission. There are challenges in diagnosing drug-resistant TB in children because drug resistance requires that you have bacteriologic confirmation. Children don't often cough TB. They usually have TB in other parts of their body. To get samples from younger children, they can't cough on command. And so we feel hampered by needing to make a bacteriologic diagnosis in children, when really it's easy to make a clinical diagnosis, and if the child has a contact with MDR, they need to be treated for MDR, and they can be treated very successfully.
So what are the practicalities of improving this situation that you're using in the Sentinel project?
Yeah, so what we're really focused on now is looking at households and having household interventions. If there's an adult with drug-resistant TB, there are usually 2 kids in the house who need to be assessed and evaluated to see if they're sick with MDR-TB, to see if they've been infected, and if they've been infected, putting them on preventive therapy. And if they haven't been sick or infected, monitoring them closely for at least a year to make sure they don't develop symptoms. The other issue that we're trying to work on is more of a community-based approach to pediatric drug-resistant TB. Right now, it's very tertiary hospital, centralized care, and children and their families can't get to those hospitals, and they often become sick and die on the way. So we want care for children with drug-resistant TB to be based in the household and the community.
Well, with multi-drug resistant TB, it would be very nice to have new drugs, wouldn't it? Any hope of that?
So we have great, exciting hope. For the first time in almost 50 years, we actually have 2 new drugs for the treatment of tuberculosis that were approved by stringent regulatory agencies. And right now, the World Health Organization is trying to work with countries to help them get access to these new drugs and introduce these new drugs under program conditions.
What would you advise healthcare providers and communities to be doing as their priorities? Because we do know a lot about TB, but the problem is actually implementing it, isn't it?
Absolutely, and the implementation gap is something we talk about over and over, and that is why we see better diagnostics for drug-resistant TB, but in fact, fewer patients, a much smaller proportion of patients compared to those diagnosed being started on treatment. And I think the issue is that providers and policymakers and public health people, we've wanted it to be about us and doing treatment that's convenient for us and that works the way that we think it should. So we make the patients come every day to pick up their prescription or to watch them take the medication. We haven't listened to patients about what they need and what's convenient for them and how to make treatment a reasonable part of their lives.
You've worked for quite a long time in Peru, Russia, and Lesotho, and a long study based in the community. What did you find from that study about the techniques for implementing these systems?
So what we found, this issue of compliance is an important one, and we found a couple things. One, if you do community-based care that's convenient for patients, their ability to adhere to therapy increases dramatically. So much of the care is based on what's convenient for providers and not patients. The other thing we found is that if you engage patients as part of the patient care team, they're much more likely to be adherent. In TB, we tend to say, do this, do that. And then the other thing we found is that when patients are non-adherent, it's not because they don't understand they need to take their medications. It's usually because they have much more pressing health or social needs. Their children may be hungry. They may need to return to work in order to make an income. And so if we're able to address those social and economic needs, not in a let's talk about it fashion, but in a very real and concrete fashion, it increases the patient's ability to comply, to be an active member of the team, and to have successful treatment outcomes. So our key findings are that we need to do a better job identifying those children and prioritizing their needs. There are no child-friendly formulations of any of these medications. There's no good diagnostics. And we really need to say, how do we get all of these children better? What we found is that a lot of the companies and researchers, they want to know the numbers. How many kids are there? We need to have a market approach and how we're going to approach this. There will never be enough children with drug-resistant TB to make a profit or to make a market approach reasonable. What we found is that for children, we need to call upon, sort of the dignity of our profession and the compassion in our souls to say, if children with drug-resistant TB aren't doing well, then we are failing as a community, no matter how many other indicators we have there.